Hi guys, so we will now tackle about acute lymphoblastic leukemia. As promised, magagawa po ako ng mga tutorial videos which we will use to incorporate ng mga ideas na nahihirapan po tayo. And I hope na makatulong po ako sa inyo sa maliit na paraan po na ito. So meron po akong kinuhang verse, yan, Philippians chapter 4, verse 13. So I can do everything through Christ who gives me strength. So I hope we can use the silence to pray to our Lord Jesus Christ. Lord, I hope na yung mga nakikinig po, makuha po nila o ma-adapt po nila yung mga lectures na itatakal po namin. And I hope, Lord, each day na dumadaan ay maging kaagapay po namin kayo at huwag niyo po sana kami pababayaan. I-guide niyo po kami, Panginoon, upang dumating na rin po yung araw na pinakahihintay po namin lahat na magkaroon po ng RMT at the end of our name. Lord, kung ano man po ang tagumpay na matatanggap po namin after this board exam, iaalay po namin po ito sa inyo. Dahil kayo po, ganun na lang po sa amin. At kayo rin po ang aming magiging hangganan. And kung ano man po ang triumph na mangyari, it will all be done to your glory. So, please, Lord, direct our steps. And we will soon become RMTs. In Jesus' name, amen. So now, guys, let's proceed to leukemias. So leukemias, they come from a broad term and derived from Greek words, leukos meaning white and hema meaning blood. So leukemias, they are popularly known as the cancer of the blood. Pero aside from white blood cells, they also infect yung mga immature erythroid and yung ating megakaryocytic cell lineages. Because as you go back from hematopoiesis lectures, na meron tayong common progenitor na doon nagmumula yung ating erythrocytic saka yung thrombocytes or yung megakaryocytic cells. So, yan. Ang common progenitor po pala nila is the CFU gem or colony-forming units, granulocytes, erythrocytes, monocytes, and megakaryocytes. So, yun. Hindi ko naman po masyado itatakal yun because medyo broad po yun. Sa hematopoiesis na po yun. So, let's proceed na po sa differentiating ng distinguishing acute leukemias from chronic leukemias. So, kapag acute leukemias, they are characterized by symptoms of short duration and many immature cells form in the bone marrow or the peripheral blood. So, kapag acute leukemias po, ito po yung ang onset ng kanyang symptoms ay abrupt. Abrupt ang onset of symptoms. They usually take weeks or days lang. Kapag naman po chronic leukemias, the onset of symptoms are gradual, or chronic leukemias have symptoms of long duration, and mostly po, ang mature cells ang nakikita natin sa mga chronic leukemias. So, itong topic natin ay acute po muna. So, ayan. Acute leukemias refers to the rapid and clonal proliferation in the bone marrow of the lymphoid and myeloid progenitor cells known as lymphoblasts and myeloblasts. So, katulad na sabi ko, rapid or abrupt ang onset or proliferation ng abnormal cells sa ating acute leukemias. Then, there are two classification systems. There are FAB and there is also yung World Health Organization. FAB meaning French American British classification system defines acute leukemias as presence of greater than or equal to 30% blasts in the bone marrow, and World Health Organization defines acute leukemias as presence of greater than or equal to 20% blasts in the bone marrow. So, please remember these values, guys, because it is one of the recalls from previous examinations. So, kapag FAB po, greater than or equal to 30% blast ang requirement po ng classification to consider acute leukemias. Kapag naman World Health Organization, they require at least 20% or greater than 20% na number of blasts in the bone marrow to classify the disease as acute leukemias. So, yan. Next is how do we classify leukemias? So, there are two classification systems. First is FAB, the next is World Health Organization. So, ito yung differentiating these kinds of classification. Kasi may kanya-kanya silang criteria. So, ang FAB natin, ang criteria niya is morphology, cytochemical staining, and immunophenotyping. Ang cytochemical staining po, ito po yung ating mga periodic acid shift, Sudan black tea, and myeloperoxidase. Kapag immunophenotyping naman po, ito po yung ating mga surface markers or yung ating mga cluster of differentiation markers. Yan. Because they help us identify or indicate the cell lineage of a certain cell. Then, morphology naman po, ito yung nakikita natin sa ating microscope. Nga pala, there is a question na first test used to classify leukemias. Ang sagot po dun ay morphology and cytochemical staining. So, they are the first test na ginagamit para maklasify or mag-categorize natin yung mga leukemias. Next, World Health Organization, ang criteria naman po nila ay halos same lang din ang FAB, may mga nadagdag lang. So, first is morphology, second is cytogenetic staining, third is immunophenotyping, then, eto may additional sila, additional the cytogenetic analysis or genetic analysis, and also clinical features. So, ang World Health Organization, gumagamit po sila ng mga syndromes or features and kinokorrelate po nila ito dun sa leukemia ng patient. So again, nabanggit ko na po ito kanina, criteria for diagnosis of acute leukemias, kapag FAB greater than or equal to 30%, kapag naman World Health Organization greater than or equal to 20% plus. So ang use, kapag FAB or French American British classification, this is the first system used, and it is now replaced by the World Health Organization criteria, but some countries still use this classification. So, meron pa rin po mga doctors and technicians na gumagamit ng FAB classification. So, hindi pa siya talaga completely obsolete. So, ang World Health Organization naman po natin, ito yung widely used criteria, plus it is more reliable as compared dun sa FAB classification. Hello? Sensya na po pala guys, kanina medyo namalat. Minom na po ako ng tubig. Wala po akong corona, huwag mag-alala. Tagal na po ako nabubulok dito sa bahay. So, yan. So, let's proceed. Acute lymphoblastic leukemia. So, acute lymphoblastic leukemia is the most common cancer in children, representing 23% of cancer diagnosis among children younger than 15 years of age. So, kapag tinanong po tayo, ano po yung leukemias most commonly affecting the childhood population, ang isasagot po natin, or ang most likely na answer, is acute lymphoblastic leukemia. ALL has a bimodal age distribution, meaning it can have an onset on a certain age and another certain age population. Yan. So, bimodal age distribution, peaking in children between 3 and 5 years of age, and again in persons older than 65 years old. So, although most commonly po pala, na infect niya is si children, yung mga children, most commonly na infect ng ALL ay children, meron din po tayong tinatawag na adult type of ALL. So, hindi lang siya for bata lang. So, pediatric ALL occurs slightly more often in boys than in girls, and in white children more often than in black children. So, mas common po siya sa mga batang lalaki, and mas common din po siya sa mga white or Caucasians. So, next. Clinical signs and symptoms of ALL. So, this includes the following: fatigue, fever, and infection. These three are common in cases of leukemia. So, fever, alam naman natin, it's a sign of inflammation. Parang signaling na yun ng body natin na something is wrong. And then, fatigue naman, probably, nagkakaroon ng difficulty ng exertion ng mga activities. It can also be due to the underlying anemias. Pwede rin kasi, meron kasing mga leukemias na meron silang anemias also because nahihirapan nga mag-produce yung ating bone marrow kasi meron ng proliferation ng abnormal cells. So, infection naman, dahil kahit na madaming WBC, ang patients with leukemia, these WBCs are defective because they have abnormal development. So, headache, because some patients have increased intracranial pressure, gawa nga po nagkakaroon ng nerve infiltration ng mga leukemic cells. Next, nausea and vomiting. Bone and joint pain is also common because these bones, yung normal architecture niya or yung normal hematopoietic cells na nasa loob ay napalitan na ng malignant leukemic cells. Pain in the extremities, particularly the legs, again, meron tayong infiltration ng mga leukemic cells because these leukemic cells can be distributed all over the body in different types of tissues. So, petechiae and other evidence of hemorrhage, and pallor, because some patients experience thrombocytopenia. GI hemorrhage is a less common finding. Hematuria is less common. Lymphadenopathy and hepatomegaly is also present. Then leukemic meningitis and cranial nerve palsies is also present. So, ito yung dahil na nagkakaroon ng infiltration ng malignant cells or leukemic cells sa nerves or sa areas around the brain. Nephropathy naman, this is true or this is because of the consequences ng treatment dun sa leukemias. Kasi ang nangyayari, na-expose yung mga purines coming from the nucleus or yung DNA. So, probably, meron kasi tayo tinatawag na tumor lysis syndrome, and this has hyperuricemia. So, it can cause damage to the kidneys, yung uric acid na nag-accumulate sa blood. So, meron akong photo dito, grabbed from Turgeon. This was the prognosis of acute lymphoblastic leukemia. So, basahin ko na lang. The improvement in survival for children with ALL over the past 35 years is one of the great success stories in cancer treatment. In the 1960s, less than 5% of children with ALL survived for more than 5 years. Today, about 85% of the children with ALL live 5 years or more, and 78.1% for 10 years. Treatment of adult ALL has lagged behind the results of treatment achieved with children. So, ang sinasabi lang po dito guys is yung mga nadadiagnose natin na childhood ALL, most likely they have good prognosis as compared dun sa adult type of ALL. Because sabi nga, mas maaga na nadetect, and meron na rin kasi tayong mga further developments, treatments nila. So, mas napapaganda natin yung kanila, mas napapahaba ang kanilang life expectancy kapag tinreat yan ng acute leukemias, acute lymphoblastic leukemias. Nga pala guys, kapag pala hindi na-treat agad ang acute leukemias, pwede silang mamatay within a number of days or weeks because dahil nga abrupt ang onset and sobrang rapid ang kanilang proliferation as compared sa chronic, which is a gradual or long duration yung proliferation nila. So, kapag untreated ang chronic leukemias, they can survive up to months, up to several years pa. Okay, so yan. Classification of acute lymphoblastic leukemia. So, ito yung FAB classification na sinasabi ko. Ito yung L1, L2, L3. I know familiar na kayo dito. So, kapag L1, mostly affecting children. L2, mostly affecting older children and adults. Then, L3, this is the Burkitt type. So, this can occur in patients with leukemia secondary to Burkitt lymphoma, ang L3. So, ito yung differentiation ng L1, L2, and L3. So, L1, meron tayong small cell or homogeneous. So, yung characteristics ng cell niya is maliliit. And homogeneous, yung sabihin pare-parehas ng size. So, isipin na lang po natin as mnemonic is yung mga sanggol. So, maliliit sila and halos magkakamuka. Next, ang kanilang ang L1, ang cytoplasm niya is scanty cytoplasm in inconspicuous nucleoli. Sabihin ng inconspicuous ay hindi siya mabilis mapansin or hindi siya mabilis makita. So, L1 has the best prognosis among the three, and it is also known as the childhood ALL, ang L1. Ito rin yung most common type among the three. So, positive siya sa periodic acid shift, yan, which is a stain for glycogen. Mamaya, itataka ulit natin siya. L2 naman, this can be seen, ang makikita mong mga cell dito ay large cell, tapos heterogeneous. Isipin mo na lang mga teenage. So, mga lalaki na sila, pero heterogeneous, iba-iba. Merong, hindi ganun katangkad, merong mga ganun. So, large cell, heterogeneous in distribution or in appearance. They have the clefted nuclei. They have a clefted nuclei with nucleoli. So, it is also known as the adult type of ALL, and positive din po sila sa pus. Yan, L1 and L2 are positive sa pus. So, yan, clefted nuclei, pakitandaan na lang po ang L2. Yun po yung may lymphoblast, may clefted nuclei, si L2 po yun. Again, so, let's proceed to L3. L3 has large lymphoblasts and homogeneous. So, malalaki at pare-parehas. So, they have prominent vacuoles. So, ito, pakitandaan to. They have prominent vacuoles, ang L3. And the prognosis is poor prognosis ng L3 because it is the rarest subtype. So, aside from being the rarest subtype, medyo bihira din gumaling ang patient ng diagnosed with L3. Then, as compared sa L1 and L2, si L3 po ay negative sa PAS or periodic acid shift. Okay. Hello guys, so this is a photo grabbed from 3rd John. So this discusses the fab type L1, L2, and L3. So the size of ito, ulitin lang ulit natin yung morphological classifications and characteristics nila. So the size of blast for fab type L1 is small, while for L2, it's large and heterogeneous, or yun nga, iba-iba. Size of blast sa L3 is large. Then for nuclear shape ng L1, indistinct or inconspicuous. Next, ang kanyang nuclear shape naman ni L2 ay indented or prominent. The nuclear shape for L3 is regular, oval to round. For nucleoli naman, ito yung maliliit na dots na nakikita sa loob ng nucleus. For L1, scant. For L2, large and abundant. For L3, it's prominent and basophilic. For cytoplasm naman, L1 has invisible cytoplasm. So, sabihin, sa sobrang laki ng kanyang nucleus, hindi na makita yung kanyang cytoplasm. Then for L2, they have moderately clefted cytoplasm. And for L3, they have prominent vacuoles. So, next. So, World Health Organization classification of leukemias. So, World Health classify anemia based on their cellular morphology, cytochemical staining, immunophenotype, cytogenetic abnormalities, and clinical syndrome. So, yung World Health classification of leukemias is the current standard, guys. It's the current standard for diagnosis of leukemia. So, here is the example of classifications of the certain anemias. It was from products itong picture na to. Okay, next. So, ito yung mga special anemias na tinaka sa Rodax. So, B. Lymphoblastic leukemia or lymphoma or B. ALL is subdivided into 7 types that are associated with recurrent cytogenetic abnormalities. Although T. Lymphoblastic leukemia or lymphoma have abnormal gene rearrangement, none of the abnormalities is clearly associated with specific biologic features. Thus, T-ALL is not further subdivided. So, kanina nga po, ang World Health Organization, nagka-classify po sila ng anemias according to clinical features or syndromes. So, example po ito nun, dahil nga daw po hindi specific ang biologic features ng T-lymphoblastic leukemia, hindi na po sila nagkaroon ng subtypes or hindi na sila divide pa into certain subtypes. Then, T-ALL is seen most often in teenage males, so more on teenage males. So, para po matandaan natin, yung T sa teenage males, yun, T, common T. Tapos, for T, parang Thomas, ganyan. T for Thomas, so, males with mediastinal mass and elevated peripheral blast counts, meningeal involvements, and infiltrations of extramyocytes. So, lymphoblasts may vary in size, but fall into 2 morphologic types. The most common type seen is the small lymphoblast, about 1 to 2.5 times the size of a normal lymphocyte, with scant blue cytoplasm and indistinct nucleoli. So, itong sinasabi nilang lymphoblast, ito yung nasa Fab L1, because Fab L1 has scant cytoplasm and indistinct nucleoli. At small din ang kanilang lymphoblast, diba? Small and homogeneous. So, here's an example picture of the lymphoblast associated with ALL. Yan. So, yung letter A, ito po yung lymphoblast. Yan. With inconspicuous nucleoli. Ito naman pong picture sa letter B, ito yung myeloblast. Nga pala, kasi sabi po sa handouts pala ni Sir Kevin na ang mga hematopoietic stem cells, progenitor cells, lymphoblasts, and myeloblasts are difficult to distinguish by morphology alone. So, kaya kailangan po talaga natin na mag-immunophenotype and also yung genetic abnormalities saka cytochemical staining for proper diagnosis ng patient with leukemias. So, next is laboratory data. So, approximately 60 to 70% of patients with ALL have leukocytosis or increased WBC count ranging from 50 to 100 times 10 raised to the 9th power. Then less than 15% of the patients have extreme leukocytosis. So, sobrang severe ng pag-increase ng WBC nila with more than 100 times 10 raised to the 9th power per liter. About 25% of the patients naman have leukocytopenia or decreased WBC count. So peripheral blood smears show a predominance of blast cells in about 50% of patients, and in addition to blast, the peripheral blood is usually composed of close to 100% lymphoblasts, lymphocytes, and smudge cells. So the blast forms have one or two nucleoli in the nucleus, and our rods are absent in the cytoplasm. So ang our rods, ito po yung mga intracellular needle-like shapes na nakikita natin sa mga myeloblasts and promyelocytes. So hindi naman po kasi sila galing sa common myeloid progenitor. So, it is common na hindi nalaga, it is also a basic knowledge na hindi siya present sa lymphoid. Kasi ang our rods is mainly for myeloid lineages. Next, itong smudge cells naman po, these are, it can also be an artifact aside from being, ito kasi yung mga lymphocyte na fragile na sumabog. So, nakikita nyo yung kanyang nucleus na lang. Pero usually, ang smudge cells po natin, associated sila sa CLL or chronic lymphocytic leukemias as compared sa ALL or acute lymphoblastic leukemias. Pero there are also cases na nakikita sila sa ALL. Smudge cells. So, ito po ang itsura ng smudge cells. They represent disintegrated lymphoid cells and are typically seen in peripheral blood films of CLL patients. Cells can be a natural artifact produced in the preparation of blood smears. It represents the bare nuclei of lymphocytes and neutrophils, and these cells can be seen when there is increased fragility of cells. So, yeah. Most commonly, nakikita siya sa CLL or chronic lymphocytic leukemia. Pero according to Turgeon, it can also be seen in some cases of ALL. Kaya siya nagkakaroon ng smudge cell because there is increased fragility of the cells, particularly lymphocytes o kaya pwede rin neutrophils. Pero meron ding artifacts na napoproduce kapag gagawa ka ng blood smear. Next, cytochemical staining of ALL. So first is periodic acid shift or PAS. It stains the intracellular glycogen bright pink. Then it is positive for immature lymphoid cells, malignant erythroblast, and megakaryocytic cells. So ang periodic acid shift natin, it is not specific, pero it can be a valuable data or valuable test to diagnose erythroleukemia, which is FAB-M6, then acute lymphoblastic leukemia. So negative po dito si myeloblast and normal erythrocytic cells. It is useful in the diagnosis of erythroleukemia or FAB-M6 and acute lymphoblastic leukemia L1 and L2. So dun sa picture, ang caption natin is 30 to 40% of leukemic lymphoblasts may show a strong course or block-like positivity. So, block-like positivity po ang staining pattern ni lymphoblast sa periodic acid shift. Again, block-like positivity or strong course block-like positivity. Strong course block-like positivity. So, next is ito. I've also added yung other diseases tsaka mga cells or inclusions na nagpa-positive sa PAS. So, this includes Gaucher's disease, FAB-M6 or erythroleukemia, L1, childhood ALL, L2, adult type of ALL, then Dole bodies. Immunophenotyping of ALL. Although morphology is the first tool used to distinguish ALL from AML, immunophenotyping and genetic analysis is the most reliable indicators of cell's origin. So, nung mga unang panahon, wala pang advancement sa diagnosis and mga techniques natin to test. these leukemias, ang talagang ginagamit lang ng mga technologies is morphology, tsaka yung cytochemical staining. Yun lang ginagamit ng mga doctors, pathologists, and technologists. Pero due to advancements, it proves to be more reliable indicators of cell's origin. So both NT and B cells are derived from lymphoid progenitors, so both have CD34 surface markers and express positivity with terminal deoxynucleotidyl transferase and HLA-DR. So yung CD34 po, ito po yung classical hematopoietic stem cell marker. So pareho kasi ng origin yung T and B cells, yung common lymphoid progenitor, so parehas sila nag-express ng CD34 and also parehas din po sila nag-express ng TDT and also yung HLA-DR, which is part of MHC class 2. So, ito. Terminal deoxynucleotidyl transferase is an intracellular enzyme that catalyzes the non-specific incorporation of nucleotides into DNA. So, this is from Rodax, ALL subtype and their corresponding immunophenotype. So, early or pro or pre-B ALL has the following markers: CD34, CD19, cytoplasmic, CD22, and TDT or terminal deoxynucleotidyl transferase. Then intermediate common BALL has CD34, CD19, and additional CD10, cytoplasmic CD22, and TDT. Sa pre-BALL, it has the same markers, pero may additional na cytoplasmic mu chain and TDT is variable to pre-BALL. So, kung maaalala nyo sa pre-B cell, meron tayong cytoplasmic mu chain, di ba, na napo-form in IS. So, yan. Tapos, ito, TDT niya is variable. Sa TALL naman, palatandaan natin, pag T, single digit lang. So, ito na yung mga markers niya, CD2, CD3, CD4, CD5, CD7, and CD8, and also TDT. Walang CD6 dito, guys, 2, 3, 4, 5, 7, and 8 lang po. Yan. So, ito po, from Turgeon. Next slide. Hindi ko na po siya i-discuss. Pwede nyo na po siyang picturean para meron po kayong guide. Ito po yung kanilang pattern of immunological markers. So, yung KALA po is associated with cluster of differentiation 10 or CD10, yung KALA. Tapos, yan yung iba pong markers nila. Next slide na po tayo. Genetic and molecular findings. A majority of TALL have mutations involving Notch1 gene, which alters the Notch receptor signaling pathway responsible for normal T cell development. B. Lymphoblastic leukemia / lymphoma with translocation from chromosome 9 to chromosome 22 or QARM34 and QARM11.2. Forming BCR-ABL, one mutation in Philadelphia chromosome-positive ALL has the worst prognosis among ALLs. So guys, familiar po ba kayo sa Philadelphia chromosomes? They are associated mostly, 90% of the case, sa CML, chronic myelogenous leukemia. But according to Turgeon, Philadelphia chromosome can also be associated with certain types of ALL, and this type of ALL has the worst prognosis as compared dun sa CML na merong presence ng Philadelphia chromosomes, which indicates a good prognosis. Kapag CML or chronic myelogenous leukemia, presence of Philadelphia chromosome indicates good prognosis. Kapag naman ALL, presence of Philadelphia chromosome indicates bad prognosis or worst prognosis among ALLs. Tapos ito pala, yung Notch1 gene. So palatandaan ko na lang dito is may T sa word na Notch. So Notch1 gene involves majority of the mutations in TALL, and Notch receptor signaling pathway is responsible for normal T cell development. So, Notch T. So, next. Yung ating Philadelphia chromosome positive, the ALL, it is more common in adults, and imatinib, a tyrosine kinase inhibitor drug, is used to treat CML, has also improved the survival of the patient with this type of ALL. The BCR-ABL translocation 9 to chromosome 22. Yan. Translocation qualitative assay by RT-PCR should be ordered to screen patients suspected of ALL or CML for the presence of BCR-ABL transcript. So, kailangan i-screen muna siya and to differentiate both kasi magkaiba po yung mode of treatment ng dalawa. So, yan. Ito po yung mga translocations involved into certain types of leukemia. And ito po yung decoding, kung ano po yung ibig sabihin ng mga yon. Picture nyo na lang din po. Para po may guide po kayo. So, next na po. So, mixed lineage leukemia. Mixed lineage leukemia, nakita ko sa Rodac. And also, ito naman kay Dear John. So, B. Lymphoblastic leukemia / lymphoma with translocation from chromosome 11 to 23. So, MLL stands for mixed lineage leukemia. Rearranged is more common in very young infants, and the translocation may even occur in utero. This leukemia has a very poor prognosis. So, mas mataas ang risk ng mortality sa mixed lineage leukemia. And according to Turgeon, this mixed lineage leukemia is a new drug-resistant form of childhood leukemia. And this form, MLL, has been established to be a distinct disease and not a subtype of the prevalent ALS. Using DNA microarrays technology, gene profiles of more than 12,000 genes established that 1,000 genes were underexpressed, Basta yan, drug-resistant form siya, and it is separate from yung na-discuss natin na BALL kanina. Tsaka mas mahirap po siyang gamutin. Kaya, very poor yung prognosis ng mixed lineage leukemia, or MLL. So next, treatment of ALL. Treatment regimens differ for Philadelphia chromosome positive and negative ALL. First and second generation ABL kinase inhibitors have become the frontline therapy in cases of Philadelphia chromosome positive ALL, incorporating imatinib mesylate, an inhibitor of BCR-ABL tyrosine kinase, into the hypercytoxan cyclophosphamide, vincristine adriamycin or doxorubicin, dexamethasone hyper-C VAD regimen for the adult ALL with translocation 922 has improved the patient outcomes compared to our regimen. So, ito na lang tandaan natin, imatinib. Although hindi naman kasi natin, rarely ask questions ang mga treatment. So, most commonly sa mga doctors na po yun. Pero, it's a nice to know topic na imatinib mesylate is used to inhibit BCR-ABL formation. And so, last slide. Ito po yung mga dito. Ito yung itsura niya, yung itsura ng mga blast cells under the microscope. Yan. Oops. So, yung A, ito po ay yung Fab L1. This one, itong A part. Ito nyo, small. Tapos, inconspicuous nucleoli, hindi mo siya makikita. Tapos, scanty ang kanilang cytoplasm. Then, yung letter B is Fab L2. Ito po yung may clefted cytoplasm. Yan, clefted cytoplasm. And also, abundant yung kanilang, dito. Malalaki po sila. Large and abundant. Tsaka, magkakaiba din po yung size. Merong mga medium lang and merong malalaki. So, large and heterogeneous L2, Fab L2. Yung C naman, ito yung Fab L3. This one. Yan. So, kitang-kita nyo naman po, prominent ang kanyang vacuoles. Dito po yung mga parang butas-butas sa cytoplasm niya. And they are very large and also homogeneous. So, pare-pareha silang malalaki. Itong D is yung type ng ALL with cytoplasmic granules. So, medyo granulated siya. This is from a bone marrow smear. So, yun lang po, guys. Thank you for listening. And I hope you did learn. May mga natutunan po kayo kahit pa paano. Thank you.